Welcome. Today we shall be looking at tension pneumothorax, where we shall be discussing the pathophysiology, the diagnosis, the presentation, and the management of this condition. A tension pneumothorax occurs when air enters into the pleural space through a one-way valve mechanism. This means that with every breath, air gets trapped inside the chest cavity but it cannot escape. As the intrathoracic pressure increases, it causes the affected lung to collapse and pushing the mediastinum together with the great vessels into the opposite side. This severely compromises both the respiratory and cardiovascular function. If tension pneumothorax is untreated, it can lead to rapid hemodynamic collapse. To understand what goes wrong in tension pneumothorax, we must first know the normal physiology of the pleural cavity. The pleural space lies between the visceral and the parietal pleura, and it normally contains small amount of lubricating fluid, about 10 to 20 milliliters. This maintains a negative pressure around 5 centimeters of water. This negative pressure keeps the lungs inflated by opposing their natural elastic recoil. Looking at the difference between a simple pneumothorax and a tension pneumothorax, a simple pneumothorax involves air leakage into the pleural space, causing a partial lung collapse. However, in tension pneumothorax, air continues to accumulate without exiting. This leads to an exponential rise in this intrathoracic pressure. This not only collapses the lungs, but also it shifts the mediastinum, compressing the heart and the great vessels, and resulting in a life-threatening hemodynamic instability. Tension pneumothorax can result from trauma, whether blunt, such as a rib fracture, or a penetrating trauma, for example, stab wound. It may also develop in patients on positive pressure ventilation, especially if they have an underlying lung condition, for example, chronic obstructive pulmonary disease or asthma. It can as well result from central line insertion and other invasive procedures into the chest cavity. Looking at the pathophysiology, during inspiration, air enters into the pleural space through the pleural defect. However, due to a one-way valve effect, that air that has gotten in the pleural space gets trapped and cannot escape during expiration. This builds up intrathoracic pressure, causing the affected lung to collapse. The mediastinum then shifts to the opposite side, compressing the vena cava, reducing the venous return, and this is what leads to an obstructive shock, which is a form of circulatory failure. Clinically, patients typically present with sudden onset of a severe dyspnea and chest pain, and on examination, you may find hypotension or low blood pressure, tachycardias due to obstructive shock, distended neck veins from an impaired venous return, and even some of these patients in severe cases will show tracheal deviation, and this occurs away from the affected side. Breath sounds may be absent on auscultation and the patient may appear agitated or cyanotic. On examination, the key physical signs include asymmetrical chest expansion, hyperresonant percussion on the affected side, and absent breath sounds on auscultation. A tracheal deviation is a late and ominous sign which is present in patients with severe tension pneumothorax. In the diagnostic strategy and approach, in an emergency situation, the diagnosis of tension pneumothorax is primarily clinical. You should never wait for imaging if tension pneumothorax is suspected. In stable patients, a chest X-ray may show a complete lung collapse with mediastinal shift, and point-of-care ultrasound can be useful and typically shows an absence of lung sliding and a barcode sign or an M mode. The first life-saving step in tension pneumothorax is a needle compression. In needle compression, you need to insert a large bore cannula, typically the gauge 14 or gauge 16, into the second intercostal space at the mid-clavicular line, or the fourth to fifth intercostal space at the anterior axillary line. This allows the trapped air to escape, relieving the intrathoracic pressure. However, it is only a temporary measure. A chest tube may follow immediately. You need to be prepared with the right equipment for needle decompression, which involves a 14 or a 16 gauge cannula, a syringe, an antiseptic solution, an occlusive dressing, and appropriate protective gears. When looking at the definitive management and supportive care, a chest tube thoracostomy is the definitive treatment in tension pneumothorax. You need to insert the tube at the fourth or fifth intercostal space at the mid-axillary line, then connect it to a one-way drainage system. As well, you need to confirm the lung re-expansion with a follow-up chest X-ray after chest tube placement, restoring the negative pressure and preventing recurrence. In the supportive care of tension pneumothorax patients, you need to administer high-flow oxygen and manage the airways needed, and for hemodynamically unstable patients, administer intravenous fluids cautiously and consider the use of vasopressors. Continuous ICU level monitoring is essential post-decompression to manage the complications and evaluation of lung recovery. And when looking at the complications and the prognosis of tension pneumothorax, if tension pneumothorax is left untreated, it can cause cardiac arrest, emphysema, empyema, recurrence, hemothorax, subcutaneous emphysema, lung injury, and early actioning is usually associated with a favorable outcome. Some nursing responsibilities for patients with tension pneumothorax include an early recognition, preparation of equipment, assisting with the decompression procedure, and monitoring post-intervention care. This includes a regular assessment of vital signs, oxygen saturation, chest drainage and wound site management and care and management, patient education about the symptoms and prevention of recurrence.